Hi, everyone. Good morning, good afternoon, good evening, depending on your time zone. My name is Godwin Pius Ohemo, and it feels really, really good to have you on a call with us today. Today is the 21st day of the month of November, and we are gathered here to have a very robust conversation on the subject matter of antimicrobial resistance. We're celebrating the World AMR Awareness Week in the form of a webinar where we have carefully invited colleagues from different regions of the world and from different expertise to come share their thoughts on how we can mitigate antimicrobial resistance. On Tuesday, we were in Africa. We looked at the African strategy for mitigating AMR. On Wednesday, we were in Asia. We looked at the Asian strategy for mitigating AMR. On Thursday, we were in Nigeria, and we looked at how we could actually mitigate AMR in Nigeria as well. And today, we are in the MENA region, the Middle East and North African region, and we are going to look at how to mitigate the scourge of antimicrobial resistance in this region. So if you are just joining us, welcome. This is the World Antimicrobial Awareness Week program put together by the Antimicrobial Resistance Knowledge Hub of the Global Health Network. And the theme is, as you can see on your screen, is One Health in Action, MENA Strategies to Tackle AMR Across Human, Animal, and Environmental Health. So this is how we are going to fare today. A quick housekeeping. This webinar is being recorded and the recording will be made available on the Global Health Network platform. Due to the number of persons on the call, your microphones and cameras have been turned off. We request that you use the chat box to introduce yourself to us. We really would love to know who you are and where you are joining us from, and we'll be grateful if you could use this also as an opportunity to connect and to network with colleagues on the call as well. Once the speakers are done presenting, question can be served them by using the Q&A box. You can drop your question in the Q&A box and the speakers will attend to them either by typing their responses to it or by taking them when we move into the question and answer section properly. These are the persons who are joining us today from different countries of the world. We are glad that you could make it. Thank you so very much for joining us. The agenda for today's meeting is, as you can see on your screen, my name is Godwin Pius Ohemu, and I will serve as the chair of today's webinar. I work as the graduate assistant at the Antimicrobial Resistance Knowledge Hub of the Global Health Network. As soon as we start, our colleague, Dr. Mohammed, will give the opening remark. Dr. Mohammed is the scientific lead and regional coordinator for the Global Health Network MENA region. After that, we'll have the first presentation by Dr. Mohammed, Professor of Biomedical Sciences and Director of Center for Genomics and Vice Director of Teaching Effectiveness Office, Ziwale City of Science and Technology, Egypt. Then Dr. Heber will give her presentation. She is the One Health Technical Officer at the WHO Regional Office for the Eastern Mediterranean. Then Dr. Shafi Koya, Medical Officer, AMR and IPC, One Health Unit, Department of Health Promotion, Disease Prevention and Control, WHO Regional Office for the Eastern Mediterranean, will give his presentation as well. And then finally, Dr. Said, the scientific researcher at the Institute for Community and Public Health, Bislett University, will give his presentation, and then all the speakers will be on the call for us to have question and answer session. Our colleague Nana is on the call, and she is serving as the scribe to take note of today's presentation and to make a very robust report on what has been discussed. So, ladies and gentlemen, without wasting any bit of our time, I'd like to bring to the fore the regional coordinator of the Global Health Network, MENA region, Dr. Mohammed, to give the welcome remark. Dr. Mohammed, if you're ready, we are ready. Over to you.
Yeah, thank you so much, Yohaba. Good morning, good afternoon, everyone. It is my great pleasure to welcome you to today's session of the Antimicrobial Resistant Webinar Series. I would like to thank you all, colleagues, partners, participants from the region and beyond for joining this important discussion. As many of you know, AMR, antimicrobial resistance, is one of today's topic at the global level. threatening a human, animal, and the health of human being, as well as the food security and environmental issues. Because it spans multiple sectors, no single country or discipline or sectors addressing it alone. This is why One Health approach is really important, uniting public health efforts, veterinary, agriculture, environmental, and policy expertise to develop common and shared solution. At the Global Health Network, MENA region, our mission is to strengthen the capacity building and research and also fostering the collaboration among the stakeholders in the region. And also, we work on sharing knowledge and expertise between all state and non-state stakeholders in the region. Today's webinar reflects that mission. It offers a space and a platform to explore practical examples from the field on One Health approach and the strategies in actions, grounding four key pillars. The first pillar is policy harmonization. The second pillar, integrated public health surveillance. The third pillar is building synergies across MENA research partnerships. And finally, the last pillar is sustaining funding mechanism for supporting the One Health approach implementation. It is also provides key questions to our discussion. What is globally happening and what is working globally and regionally? What are the lessons that we can learn from adopting and implementing the One Health approach, and how we can translate the evidence into policies and practices? So I extend my sincere appreciation to all our distinguished speakers for sharing their valuable insights and for their contribution today. This work shows meaningful progress, which is actually possible when we coordinate our efforts and uniting our contributions in order to support the decision that can be actually evidence-based. I will also thank all our colleagues and partners for making this webinar possible. Your support is really important and vital as we continue strengthening research networks across the regions and beyond. Finally, I encourage all participants to engage actively, asking questions, sharing your views, and connect with one another, addressing this important topic for strategies, of course, and actions. Thank you once again for being with us today, and I look forward to an insightful and a productive session. Thank you so much.
Thank you very much, Dr. Mohammed, for that wonderful opening remark. Ladies and gentlemen, if you are just joining us, this is the World Antimicrobial Awareness Week program put together by the Antimicrobial Resistance Knowledge Hub of the Global Health Network. And we are very happy to have every one of you on the call. Already, I feel super duper excited about the robust conversation that we are going to have today. So without further ado, we are going to switch on straight to the first presentation that we are going to have today on the topic, Empowering Health System Through Genomics, Regional Strategies for Antimicrobial Resistance Control. And this presentation is going to be made by Dr. Mohammed. Dr. Mohammed is a professor of biomedical sciences. He's also the director of the Center for Genomics and vice director of teaching effectiveness office as the Way City of Science and Technology, Egypt. Dr. Mohammed, it is an honor to have you with us. If you are ready, I'll stop sharing my screen so that you can take over and make your presentation. Thank you.
Thanks, Godwin and Dr. Mohammed, for the introduction, and thanks for all the panelists for preparing for this event. So, Godwin, should I share my screen myself, right?
Yes, please do. Yes, go ahead and share your screen. Thank
you. So now you can see the screen, right?
Yes, we can see your screen.
Okay. So good morning, everyone. My talk today will be a bit concise. It summarizes most of our work on the One Health antimicrobial resistance. So my name is Mohammed Al-Hadidi, and I'm a microbiologist by training, and I received different trainings on microbial genomics and I'm also a veterinarian. So I appreciate how the One Health concept can actually be implemented to tackle many challenges that we face nowadays. So I'll just try to skip over our workflow that implements the One Health concept. As our vision at the Center for Genomics, we feel our national mandate is to provide cutting-edge research and transitional research as well. So our work is between the basic science and applied part. We also committed to provide training and science outreach activities in the field of microbial genomics and the One Health to Egyptian researchers and beyond. So we plan our vision to face these challenges. One of these challenges are the lack of genomic data in Africa. If you go into any public repositories and just see the genomic data sets in the Middle East and North Africa, or in Africa, as compared to the rest of the world, you will find that the genomic data sets is really rare. So our commitment in this, through collaboration and through building and providing some types of genomic data sets in group. Our second challenge that we see is the antimicrobial resistance. And as you all know, that the antimicrobial resistance is one of the health challenges we face nowadays, not only in the rest of the world, but also on a specific lens on Africa and in low and middle income countries. And if we explain the reason behind this, there are many reasons, including the farming system that we use and the intensive use of antimicrobials, both at clinical settings and in livestock settings and in the environment as well. So we believe that we are committed in augmenting the genomic data sets and in tackling the antimicrobial resistance using different approaches. So that's why we actually, since my leadership at the World City, we believe our mandate is to tackle the antimicrobial resistance using the One Health lens. Being in mind that the One Health lens, it doesn't only tackle the antimicrobial resistance, but also other health challenges we face nowadays. But our commitment is just to go with the antimicrobial resistance. So if you are thinking about different strategies to combat the antimicrobial resistance, you can find different approaches, either to invest in more antibiotics, and we might be afraid that the cupboard might be bare of more antibiotics, the phage therapy, the antivirulence drug, doing genomic surveillance and comparative genomic analysis, vaccines. But we believe that a combination of these approaches is really crucial. So our mandate is just like to merge different of these approaches in a One Health lens to tackle the antimicrobial resistance. So this is our mind map that we always look at when we revisit our challenges. So we make our challenges very clear: the lack of genomic data, and also from the One Health aspect, in the spillover and host jump. So pathogens can spill from one reservoir, or either the animal, and then it spilled to the human, and then it acquires many host adaptive elements, and vice versa. So this transmission might be either in one direction or a bidirectional exposure, and also the antimicrobial resistance. So these are the three main challenges that we face. So we feel our mandate is, by lack of genomic data, is doing our best to enrich our genomic data sets and integrate different machine learning and artificial intelligence approaches. And we have our workflow that actually fits with this mission. So for the transmission, we also study the reservoir system and the patho adaptation into different reservoirs. And for the lack of genomic data, we are committed in providing antivirulence drugs as well as different vaccine candidates. And if you look into the vaccines, I feel it's the best approach to tackle the antimicrobial resistance. That's just most of the funding opportunities now are actually targeting vaccines against antimicrobial resistance. So, and then you can find our workflow that can be expanded on different superbugs and WHO high priority list of pathogens as well. So why we are doing genomic surveillance? We are doing genomic surveillance or comparative genomics for many reasons: to determine phylogenies and to determine the homology between different bugs from one bug from different sources. We characterize the pan-genome analysis, and we to determine the population size, either at the global level or the national level. We also implement changes in the evolution pattern, either over time or over geographical distribution. And finally, we implement a genome-wide association studies to find novel links between a phenotype of interest like the virulence or the antimicrobial resistance and different genomic determinants. So looking into this, we have one model that I want to share our success story in the Staph aureus. So Staph aureus is one of the superbugs. It's highly virulent and it develops multiple drug resistance against different pathogens. That's why the WHO have categorized these pathogens as one of the high priority link pathogens. So why we study Staph aureus? Again, for the AMR profile, the virulence, and also the genomic plasticity of this pathogen, and also ability to transmit across different niches, either the community, the livestock, and the hospital settings. So how we did genomic surveillance at the One Health lens to characterize the genomic surveillance and the transmission pattern of Staph aureus by augmenting our genomic data sets and comparing with the global genomes. So we have actually now hosted the most important and the larger sample size of Staph aureus in Egypt, representing Africa. Almost like 600 genomes are actually deposited on the public repositories over the past year. It's a One Health, so it's characterized from the livestock and the community settings to determine if it's a spillover or a host jump. And we compare these isolates with the global genomes to determine if there is a special pattern, evolution pattern in Egypt as compared to the rest of the world, or we have a specific pattern of pathoadaptive evolution across Egypt compared to the rest of the world. So we had genomic data sets in a One Health aspect from animals, from humans, and we compared these genomes with the rest of the world, as I will mention. So this is our worldwide map for Staph aureus genomic studies. As you can see, Egypt now is hosting different genomic data sets from animals and humans, and we compared this across different clones, across the rest of all the global data sets that was actually deposited on public repositories, just to determine if there is host adaptive elements, specific virulence factors, etc. So it's not really surprising for us to see that the antimicrobial resistant and the virulence gene, or the rhizostome and the virulome over Africa, is much higher, as you can see in the first row over different 4 panels, as compared to different parts of the world. That was actually not surprising, because Africa hasn't implemented a specific stewardship system for antimicrobial resistance, and the result is a superbug that actually disseminated across different niches. When we stratify actually this virulome and rhizostome across different clonal complexes, just to avoid any kind of bias by clones, we found the same results. So for the phylogenets, as you can see in the right panel, we did a phylogenetic analysis just to compare the bidirectional exposure, and we found that the animal isolates in Egypt is actually structured or actually found in the same cluster compared to the human isolates, and we found the highest percentages of host adaptive elements that actually allow this bacteria to adapt and to transmit and distribute to different hosts. And that's actually one of the specific examples I want to mention regarding Staph aureus doing genomic surveillance in the One Health aspect. So we find our next challenge is at the translational aspect is just to find alternatives. And here in this slide, we can see the difference between applying the antivirulence drug that can be more safe than the antibiotics, as it doesn't create a selective pressure against this bug, so it can be used to disarm this bacteria. But to determine novel vaccine candidates, we need to find virulence hits, like a hit that is actually novel that we can target. So I will not explain the different antivirulence drugs that we used, but I will just try to explain our approach to find a novel hit for virulence that these drugs can tackle. We applied, talking about the virulence markers, I will also use one model virulence mechanism, which is the biofilm formation. So as you know, biofilm formation is when the bacteria aggregates and applies an exopolysaccharide matrix where it's more resistant as compared to the planktonic cells, and it's one of the mechanisms of virulence and antimicrobial resistance. So as a pilot study, we performed a novel approach that was actually implemented in our laboratory, which is the genome-wide association studies. So doing the genomic data sets and doing some kind of statistical association analysis like the unitique based or the chimer based or the SNP based, we determine novel association between different hits, either regulatory elements or genes, etc., and the biofilm formation. So we found this association links between biofilm formation and these genomic determinants. So this is our model that we implemented different statistical methods, including the binary classification of these bugs by doing association studies, augmented with different machine learning classifiers just to find specific hits for targets for virulence markers by acquisition of these genomic data sets. And as you can see here, we found 20 different biofilm-associated markers that we are currently validating using our bank of transposon mutants to validate our association and machine learning approach. So as you can see also, the genome association studies, we have implemented this GWAS at the One Health lens into different phenotypes of interest, either doing the GWAS for determining the clinical aspects of animals, like the bovine mastitis. Bovine mastitis is one of the animal health risks, as it's actually inflammation of the bladder or urinary in the mammary gland of the animal. So we also determine this GWAS at the One Health lens, not only in the biofilm formation, but also in animals for determining of the clinical manifestations of mastitis and to determine adaptomycin resistance, which is one of the last resource of antibiotics for Staph aureus. We also curious about the cross-resistance, and to make this term very simple, cross-resistance, when we use like disinfectants or different antibiotics, bacteria can acquire resistance to antibiotics by exposure to different disinfectants. And we have seen this during the COVID pandemic. So during the COVID pandemic, we overuse disinfectants just to kind of as a kind of sanitation strategy. And in our lab, we had an observational study that we found that following the COVID pandemic, the bacteria was more resistant to antibiotics. So we tried to implement an adaptive evolution strategy just to find a causation between the using disinfectants and its implication of the cross-resistance mechanism to antibiotics. So in the left-hand panel, you can find our workflow that implemented a One Health genomics approach to determine this cross-resistance mechanisms. And just like for the sake of the time, on the right-hand side, this is a spot assay that we determined that the bacteria following exposure to a super inhibitory concentration of disinfectants provided a better growth effect. So it's able to grow into a super inhibitory concentration of disinfectants and also to behave as a super bug by having a more resistant as compared to the wild type to different antibiotics of different mechanisms and to exhibit a higher ability for biofilm formation as compared. Last but not least, so we asked our final question for this presentation, how we can get a better use of genomes to provide a vaccine candidates. And here's the question. These are the different questions that we usually ask about the vaccine candidates. So our next question is how to address this question using genomic tools. So to answer this, we actually worked in a pipeline that involves different computational and machine learning tools. It's 5 pipelines. We named it anti-pan. So we retrieve the bacterial genome and we go into the pan genome analysis and then through different reverse vaccinology filters to assign a best candidate. And then we pass this into an immunoinformatics pipeline, including how it can stimulate the B and T cell lymphocytes, and which is called the B and T cell epitope mapping, and then following by molecular docking, as we can see that these targets can also enhance the innate immune defense, not only the acquired one, and can have some kind of protection by against the humoral immunity and also the cell-mediated immunity. Finally, we pass this into a protein assessment module to assess if these proteins are toxic, it is essential, etc. So by applying these pipelines, which is like these 5 pipelines that can actually be extended into different bugs, these are the pipelines that we implemented in our standalone package And these are the identified vaccine candidates. We are currently cloning these candidates and verifying the antigenicity and the protection of these candidates using different preclinical studies and animal models. So our future insight is just expand the sample size. Most of these results are a kind of a pilot, so we need to expand this sample size. We need to implement our workflow that we feel it's really can fit different multiple drug-resistant pathogens, so we can implement all this workflow for other bugs as well. Finally, I would like to thank all my funders, all my team, which I attribute most of the work to. And I would like to share a good news that I received last week, that I have been selected as the only among 16 different members of the scientific advisory board of the One Health Antimicrobial Resistance, which is part of the European Commission and Horizon 2020. Those members are actually involved in planning the strategic version of One Health antimicrobial resistance over the next 3 years. So I'm quite pleased to represent the MENA region for this initiative that actually has different capacity building, training, and funding arms. And this is our vision and mission at the European One Health Antimicrobial Resistance. Looking forward this presentation for future collaboration to transfer your vision into these initiatives. And thank you so much for listening, and pretty apologies if I'm being a bit late. Thank you.
All right. Thank you so much. Thank you so much, Dr. Mohammed, for your presentation. That was excellent. That was stellar. It was obvious all over how passionate you are about the subject matter of antimicrobial resistance and genomics. Ladies and gentlemen, if you are just joining us, this is the Antimicrobial Awareness Week webinar put together by the Global Health Network, and we are happy to have you on the call. We've had the first presentation. Without wasting any bit of our time, we are going to transition into the next presentation. And this presentation, as you can see on your screen, is focusing on antimicrobial resistance from the One Health lens. And that will be presented by Dr. Heba Marus. Dr. Heba is the One Health Technical Officer at the WHO Regional Office for the Eastern Mediterranean. Dr. Heba, if you are ready, we are ready. You can share your screen from your end, and let's learn from you. Thank you.
Thank you so much. Could you confirm seeing my screen now?
Dr. Mohammed, you can stop sharing too so that we can see Dr. Heba. I think I can see your screen on my end.
Actually, I just shared my presentation. Yes. I'm not sure if...
It's okay. Yes, we can see your screen now, Dr. Heba. Please go ahead.
Yeah, okay. Thank you so much. This is Heba Mahrous. I'm the One Health Technical Officer for WHO Regional Office for the Eastern Mediterranean. Thanks all the organizers for the generous invitation, and it's my pleasure to be with you today. So I will take you through a very quick, tour on the AMR from a One Health perspective. So first, to be on the same page, let's remind ourselves about the global impact of AMR. Unfortunately, we have new estimates reveal that 39 million deaths are really expected to be directly attributed to the AMR by 2050. And this is really very bad news that we got. And coming to our region, the Eastern Mediterranean region, we are also, unfortunately, the highest and most rapidly rising antibiotic consumption globally. Second, when it comes to antimicrobial resistance drivers, we can speak about two main components. Either these drivers are taking us toward the selection or towards the transmission of these resistant genes across human, animal, and environment axis. And these drivers, as you can see, is really huge. One of them is the improper and excessive use of antimicrobials. And then also the lack of access to clean water, sanitation, and hygiene for both humans and animals, poor infection prevention and control in health facilities as well, in addition to poor access to medicines and vaccines. Also, in addition to this, we cannot ignore about the lack of community awareness and knowledge about how to use the antimicrobials and all these details, besides finally the irregularities in the legislation, which is so important in the AMR as one of the key drivers. Coming to the One Health concept, actually the One Health concept is a little bit, we can say, in terms of the science, it's a little bit new. So we are speaking now about almost 21 years of coining the term One Health. And the One Health has been defined recently by the OLIP, the One Health High-Level Expert Panel, as an integrated unifying approach that recognizes the health of humans, animals, and the whole ecosystem are really close linked and interdependent. When we started, we have started applying the One Health approach. We have tackled the zoonotic diseases, but by operationalizing the approach, it has proven efficiency even to serve other technical areas like AMR and food safety. And now under the umbrella of One Health, you can see a lot of technical areas and a lot of threats that can be tackled by putting hand of hand all experts and stakeholders together. So a One Health response is really needed to address all these drivers that you can see that beyond the antimicrobial resistance problem. So what does it mean? It means that all stakeholders, all partners, all sectors need to be engaged along the whole story, starting from designing, starting from the planning stage till the implementation of all programs. Even they have to be hand in hand in putting all the policies, formalities to regulate this coordination mechanism across sectors. So all of these partners need to take a role and to collaborate together, to make use of the limited existing resources that we all have to against the impact of antimicrobial resistance. That's why the international organizations, including quadripartite, including WHO, has realized the importance to invest in operationalizing One Health to mitigate or to fight against antimicrobial resistance. So far, the quadripartite has developed joint secretariat focused mainly on AMR, focusing on supporting countries on this profile and developing a lot of guidelines to the countries to make use of. One of them, for example, is integrated surveillance of antimicrobial resistance in foodborne bacteria. In addition to, as you can see, guidance on the One Health priority research agenda for AMR, in addition to the global database and the global database for tracking antimicrobial resistance. It's some sort of country self-assessment survey that the countries are committed to do and to follow up on all the implementation of agreed activities across sectors. And one of the variables, as you can see, were the countries in terms of the multi-sector and One Health collaboration and coordination. From other aspect as well, the AMR has gained a lot of political support. So we can see now that the AMR and the operationalization of One Health to tackle AMR has been put on different very high-level occasions, like the third and the fourth as well, high-level ministerial conference in AMR in November 2022 and 2024. Not these high-level ministerial conferences only, even before, like 10 years back, during the World Health Assembly, there was a resolution on combating AMR, and this resolution encourages all member states to adopt national action plans using the One Health. In addition to this, a One Health AMR One Health Learning Hub has been launched during the first global high-level ministerial conference that was organized last year in KSA. And this hub really aimed to build skills across all sectors, align national and international efforts, and accelerate the practical implementation of multi-sector national action plans to combat AMR using the One Health approach. And this is supported by the WHO. In collaboration with the quadripartite. One also of the milestones of operationalizing One Health to serve AMR is to having the AMR as one of the key pillars, one of the 6 action tracks within our One Health GPA, the One Health Joint Plan of Action that the quadripartite has developed 2022, and this is our global reference towards operationalizing One Health. As I was saying, the One Health at the beginning was only focusing on zoonotic diseases, but really now it expanded to include AMR, food safety, and other problems that arise at the human-animal environment interface, and which really the One Health has proven efficiency in tackling these problems. At the regional lens, we also supported this from different activities. One of them is signing the joint statement of intent involving the 4 regional directors from the quadripartite, FAO, WAAW, WHO, and UNEP. And this also to collaborate on operationalizing One Health in the region, and this mainly to focus on zoonotic diseases, AMR, and food safety. And this is really a very good initiatives that we are committed to follow and to collaborate on. Within this statement of intent, the 4 regional directors have agreed on 2 main issues. One of the One Health Region Quadripartite Action Plan that mainly serve to implement a comprehensive regional mechanism to operationalize and support the multi-sectoral approaches to enhance the health of humans, animals, and environment, in addition to efficiently use of the One Health approach in prevention and control of health threats. For sure, the AMR is one of these health threats at the human-animal environment interface. And lastly, to promote the use of technologies, tools, and best practices to enhance data integration and information sharing. And this will serve also the fight against AMR. As you can see, the second agreed commitment is to establish a One Health regional quadripartite coordination mechanism with different levels, different TRs, roles, and their responsibilities. And as you can see, the last level of this quadripartite coordination mechanism is the establishment of regional One Health technical working groups. And we, as a regional quadripartite, we agreed to develop 3 working groups. One for zoonotic diseases and the second for food safety. And for sure, we couldn't, ignore the AMR as one of the key pillars that all the quadripartite can support the member states to tackle as well. Lastly, from a One Health lens, these are the key One Health strategies against AMR. So surveillance, for example, is one of the most important topic that all sectors, all partners, all stakeholders should collaborate to have integrated or at least coordinated surveillance for monitoring the resistance in humans, animals, and the environment. In addition to the stewardship. So the stewardship will allow us to have at the end the rational use of antimicrobials, not only in health facilities, not only in the human aspect, but also across all sectors. And this will really feed on the overall goal of fight against AMR. Third one is infection prevention. So by augmenting the hygiene, the use of vaccination, and also biosecurity measures, these all will prevent, the spread of the infection. This will minimize the need to use antimicrobials. So this is also one of the key pillars that we are tackling by One Health. Research and innovation, so developing alternatives such as vaccine, probiotics, rapid diagnostics, all of these are key, useful for the fight against AMR. And finally, to do all of this, we need to enhance our multi-sector coordination and collaboration. As I mentioned in the beginning, from the planning till the implementation, all of these need to align all our efforts. We all have a limited capacities, and then the collaboration actually is not an option. Now it has been as a crucial step towards mitigation of all the health hazards at the human-animal environment interface, and for sure AMR is one of them. That's all from my end. Thank you.
Thank you very much, Dr. Heber, for that wonderful presentation. It was straight to the point, and we really want to say thank you, thank you, thank you for how passionate you are on the subject matter of antimicrobial resistance. Ladies and gentlemen, if you are just joining us, please use the Q&A box to drop your question for our resource persons if you have any, and use the chat box to introduce yourself to us. We really would love to know you. We'd love to know who you are and where you are joining us from. Without further ado, I very respectfully want to bring to the fore another colleague of ours who is going to make his presentation, and that is Dr. Shafi Koya. Dr. Shafi Koya is the medical officer AMR and IPC One Health Unit at the Department of Health Promotion, Disease Prevention and Control of the World Health Organization. Dr. Koya, if you are ready, we are ready. Welcome to the stage.
Thank you so much. Thank you so much, colleagues. Thank you so much to the Global Health Network and all the organizers and the co-panelists and presenters today. I will take maybe 10 minutes maybe to highlight some of the very specific human health aspects on AMR. Of course, we all know that AMR doesn't exist in isolation. It is part of the bigger universe of infection, particularly when we talk about North Africa and some of the countries in the Middle East. We are talking about how we address infections which are sensitive and resistant to antibiotics. So unless we can prevent the overall or reduce the overall burden of infections, we cannot reduce burden of AMR. So maybe some of you are very familiar with this very, very recent paper, including collaborators from Oxford and University of Washington and several universities and institutions across all our countries. This is the burden of bacterial antimicrobial resistance in our region, in the WHO Eastern Mediterranean region, with projections to 2050. And you can see that we are speaking about huge number of deaths annually, which are directly related to AMR. And we also look into the data for 2021 from the same source. We can see that if you are familiar with the pathogens that are listed, it points to one common factor, which is infection prevention and control is the most critical thing that we can do, at least in some of our countries in our region, to reduce really the burden of healthcare associated infections, which are contributing massively to the burden of diseases. Over the period of over the last 30-40 years, we have significant achievements in reducing infections. So you can see that reflects in the burden of antimicrobial resistance, because from a very high burden among the pediatric population, now you can see that the graph is shifting with the burden moving towards the elderly population. With our population getting older, we are having more ICU admissions, we are moving more healthcare associated multi-drug resistant organisms. In the region, these are the top three countries with the highest number of deaths attributable to AMR. And in terms of age-adjusted mortality, in fact, Somalia is having the highest burden in terms of age-adjusted, population-adjusted, age-adjusted mortality, even much more than Egypt and Pakistan. Over the years, there have been success. There has been significant progress, but unless we take significant, very significant and substantial investment, we may not be able to achieve what we wanted to achieve. Even in 2050, things do not look very good. One of the key things that WHO supports countries is, as Dr. Heba mentioned, is the establishment of national action plans, multi-sectorial national action plans. And we can see from this graph, I will share the presentations and these papers you can access through the QR codes that I put in the slides. When countries have strong investments through national action plan, you can see that there is a very big impact in reducing the age standardized mortality rate. Again, I would draw your attention to more in-depth understanding, because I saw some comments in the chat asking for more sources of data and on literature. This is an excellent source, and I'm sure University of Oxford and is leading this work in the GRAM database on antimicrobial consumption. It's an excellent way to understand and compare between countries and over the years. Another excellent source is the WHO's most recent report on the global surveillance on antimicrobial resistance, which actually draws from 23 million cases of infections and tells you about what is happening in different regions. It's not all good. Everywhere it is increasing. For example, bloodstream infection resistance, except in Western Pacific, everywhere it is increasing. In gastrointestinal, Eastern Mediterranean region and Southeast Asia, it is really increasing. Urinary tract is increasing in resistance in the urinary tract infections is increasing everywhere, and urogenital gonorrhea infections, it's stable, but unfortunately, if you can see, it's very high in some of the regions. So when we talk about surveillance systems, again, WHO support the surveillance improvement of surveillance capacity, but you can see from this graph, we have at least 1/3 or more where we do not have all the 5 components, core components of an ideal surveillance system in at least 1/3 of our countries. I'm sure you might have already seen this. The most recent data from the countries show that at least 1 in 3 infections in our region are resistant to antimicrobial drugs, and we are same level as in the Southeast Asia region. And in our region, if you see, urinary tract infection has the highest reported resistance rate, followed by bloodstream, and then gastrointestinal and urogenital. E. coli and Klebsiella pneumonia resistant to third-generation cephalosporins and fluoroquinolones are the most commonly or frequently reported drug-bug resistance combinations. In this graph, you can see E. coli resistance to imipenem significantly increased between 2018 and 2023. Klebsiella pneumonia resistant to imipenem. So I'm talking about a drug which is not only expensive, but also one of the last resort drugs. The resistance is really increasing over the last 5 years. We're specifically looking for North Africa and MENA consumption patterns. This is an excellent graph. Again, this comes from the sources that I mentioned, that is the GRAM database. You can absolutely, it's very clear, you can see that the most highest per capita consumption is in North Africa. And among the WHO regions, as Heba mentioned, it is the Eastern Mediterranean region. But even in the Eastern Mediterranean region, just this slide, you have seen this slide before from Heba's presentation, but within our region, if you look into high-income countries versus middle-income countries versus the fragile conflict situation, the picture is very clear. Fragile conflict situation shows absence of drugs or very poor access to drugs, whereas the low-middle-income countries are really increasing their consumption rate. So I will not go to this, I've shown this, but again, in terms of our targets, global target of achieving 70% of the antibiotics coming from the access group of drugs, which are the first line drugs mostly with a very low resistance potential. We are nowhere near. Only one of the countries in the region has actually achieved that by now. Of course, even if you take 60%, which was the previous target, only 4 out of the 9 countries in the region actually achieved that target so far. What we are doing, as we mentioned, we support countries in development of national action plan. We help them put together stakeholders. We give them tools to analyze what has happened so far, understanding the strengths, weaknesses, opportunities, and threats in the country. Put together stakeholders from across the One Health spectrum and develop them. We help countries in terms of developing their surveillance system. All our countries have surveillance systems now for AMR. The quality, the EQA, the external quality assurance systems, the quality of data, the use of data may vary, but all the countries have at least a basic minimal surveillance system in place. We have 18 countries with dedicated infection prevention control units. We have several countries, I think at least 20 countries have enrolled in the GLASS antimicrobial use surveillance system, but as you see, only 9 countries are submitting data. And if you are familiar with the access, these QR codes will help you to take you to those resources. The WHO Access, Watch, and Reserve Group classification of antibiotics is an essential tool for stewardship programs. Only 9 countries in our region out of 22 have adopted these tools. So a few minutes on what next, or what are the priorities. We need to implement, not just having a national action plan paper, but we need to implement them, we need to cost them and budget them, which is only in 1/3 of the countries at the moment. Although 2/3 or more than 2/3 of our countries have implementing the national action plans, and the coordination between sectors is far from satisfactory. Funding for national action plans is a big issue. I can see only that the WHO Afro region has significant progress thanks to the lot of efforts from a lot of partner entities and agencies which actually advocated for improving the funding for national action plans. We have a huge target in front of us, as you have followed from last year's United Nations General Assembly high-level meeting, which have put very ambitious targets. But if we need to achieve that, we need funding for the national action plans. We also need to work on programs like you are doing today, awareness and education. Although there are some minimal level of awareness programs in all countries, only less than 1/3 of the countries have a national-wide AMR awareness program in place. Although there are some forms of trainings for AMR for professionals, the pre-service and in-service training focused on AMR is only in 3 or 4 countries in the region. So we need to engage more of our professional societies, our universities. We need to have more fellowships and certificate programs. And WHO is actively working with the universities and institutions in the region to develop such programs. One of the key determinants of infection is vaccination, as all of you know. So in this graph, we can really see our fragile conflict countries have very poor vaccination status, including some of the traditional vaccines. Unless we can improve those vaccine coverage, we cannot reduce the burden of infection, susceptible or resistant. So I think this is again a big priority, and we see a lot of investment happening now through other various sources, including the Gavi initiative. Infection prevention is critical, as I mentioned in my first or second slide. But again, you can see the nationwide implementation, although there are programs in most of our countries, the nationwide implementation is still very poor. We saw some significant strides in the COVID time, but still, we have come down from that level. And also for water sanitation and hygiene and waste management health facilities, we have very, very few countries having substantial investment happening in those areas. Affordable health services. We need to see what is the stock of availability of essential lab diagnostics and essential antimicrobial medicines. I think again, this is a huge area which we need investment, and especially in fragile conflict situation where we are going to focus a lot in the coming years. Again, we listened to very excellent presentation in the beginning on the surveillance, particularly on genomic surveillance. That's an excellent information for us also to explore further collaboration on that. But we also need to stabilize and strengthen the basic lab capacities and surveillance capacities, which we are trying to work with several partners, bringing in resources, including lab information management systems, and supported by Wellcome Trust and other partners. That's the end of my presentation, and happy to take on questions. Thank you very much.
Very much. Thank you very much, Dr. Koya. That was a very stellar presentation and straight to the point. You blew our mind with how detailed you were with the fact and all of the information that you have shared so briefly on the subject. Ladies and gentlemen, if you are just joining us, this is the World Antimicrobial Awareness Week webinar put together by the Global Health Network, and we are very glad that you could make it. Without wasting any bit of our time, I'm going to bring to the fore our final speaker for today, Dr. Said. And Dr. Said, please, can you share your screen, please, so that we can introduce you properly to members of the audience. Dr. Said is going to speak on the topic, One Health Approach to Antimicrobial Resistance in Fragile Health System, the Case of Palestine. Dr. Said is a scientific researcher at the Institute for Community and Public Health, Berzit University in Palestine. Ladies and gentlemen, Dr. Said.
Hello, many thanks for this introduction, but can you confirm that you hear me and see my slides?
Yes, sir, we can hear you clearly and we can see your slides.
Okay, hello everyone. Many thanks for my colleagues. I am Saeed Abu Khattab. I'm from Palestine. I am infectious disease epidemiologist, and I am working on One Health approach to apply it in academic research. So before we start, before my colleagues we treat, let's think a big questions on AMR. The first one, can AMR truly be controlled in hospital without integrated One Health surveillance system across the human, animal, food system, and the environment? The second question, what would an effective early warning system for AMR look like in humanitarian settings, in conflict zones, and why is it still missing across sectors today? The third question is, who own AMR data, and how does the lack of cross-sectoral data sharing weaken our collective capacity to respond to emerging resistance threat? This is what the meaning of AMR, my colleagues mentioned for that. So briefly, AMR not only for bacteria, when the resistance for virus, fungi, parasite, and bacteria change over time, and the medication no longer respond to medicines. AMR is a critical global concern due to the selective pressure, due to the overuse, misuse, and usage of inadequate antimicrobials on a human, animal, and as a result of contaminated environment. Okay, here is a compare between the COVID-19 and the tsunami. All my colleagues mentioned for this number, but I called it what happened in COVID-19 compare with what projected to be happened in AMR. This is compare with earthquake with slow tsunami. So what happened in COVID-19, just only earthquake. Expected in 2050, AMR will be slow tsunami, and this is why called silent pandemic. All of these numbers, I don't want to go for each number. This is, you can go briefly. I don't want to, my colleagues mentioned for all of these numbers. Now, before we are talking about Palestine, talking about geopolitical situation in Palestine. Based Palestine, or divided based on Oslo Agreement into 3 areas. Area A under completely Palestinian Authority, administrative and military. Area B under military under Israeli control, while administrative under Palestinian Authority. Area C under Israeli political and military control. Area C, 60% of West Bank lands. Okay, after 7 October, what happened in Gaza? 60% of, more than 60% of Gaza that damaged. And all of you know what has happened in Gaza now, the hospital, damaging of hospital partially or completely, the houses, everything, and the injuries. This increased the burden of AMR. And we're still waiting the data about Gaza. What's happening now in West Bank, that's damaging refugees camps, in addition to the spread of checkpoints, more than 1,100 checkpoints spread across West Bank. All of this is that impacted, damaging the infrastructure, that increased the spread of AMR pathogens, increased the burden of AMR. In addition, weakened the efforts for the surveillance system and reporting system. Palestine in 2019, this is the only data, we have a weakness of or lack of surveillance system, antimicrobial resistance attributed and associated, the 4th leading of death. What? Because we are talking about One Health, what about the consumption of antimicrobial in veterinary sector? Palestine, this is a small country, one of the hotspot based on the study that published in 2023 in using antimicrobials in food and in animal production. We have at policy level, we have national action plan. That include improving public awareness, strengthening national surveillance, infection prevention, optimize use antimicrobials, and encourage and promote operational research. At Birzeit University, at Institute of Community and Public Health, what we are doing now is applying, I want to give you some studies or some projects that we are conducting. The first one, making food safer in Palestine, a One Health approach to antimicrobial resistance. In this project, we targeted the leading cause of gastroenteritis and leading cause of foodborne pathogens, Salmonella enterica, the first pathogen, and Campylobacter. The first study, before we start the project, we conducted a systematic review and to assess the situation at regional level. The systematic review that's assessed the applying integrated surveillance system, One Health approach on Salmonella and Campylobacter to assess the prevalence, serovar, and phenotype and genetic of antimicrobial resistance in the Middle East. The study findings, One Health approach was not strictly applied. Second, weakness of epidemiological study design. The included article that not strong in epidemiological design. insufficient laboratory techniques to monitor antimicrobial resistance, but also significant variation in data reporting between the countries. 60% of the included articles only from one country, from Egypt, no data from Gulf countries. The second article assesses the food production chain from farm to fork. The study findings that mentioned to the main obstacles to improve food safety and AMR in Palestine. They were overuse of antimicrobials, system fragmentation, and this is the fragile system, insufficient infrastructure, a lack of regulation and control, and poor hygiene practices. The study recommended to applying integrated surveillance system must be established in Palestine. To assess if it works or not, we went to the third study. Samples collected from same places at same time. So we have spatio-temporal design. And we targeted the poultry production as an industry, not as an agriculture production, because now in Palestine, this is advanced, so not a traditional agricultural production. So the farms, from the environment of the farms and from the food, from the meat, and from the workers over the production chain. The bacteria isolated, confirmed on VITEC and PCR, and susceptibility carried out. The results mentioned of the prevalence of Campylobacter jejuni and Salmonella enterica in the farms, food, and over the production chain. But we didn't stop here. We moved to apply whole genome sequencing on the isolates, on Campylobacter isolates and Salmonella isolates. For Campylobacter, this is the phylogenetic tree. The results that showed all the isolates clustered phylogenetically together without any difference between the source. All the isolates were Campylobacter jejuni subspecies jejuni. What we shocked from, that's the turnover of bacteria. The bacteria changed 2% in nucleotide over a year. So that's collected in 2021, completely different on that collected in 2022 in terms of resistant genes. And this is that lead to 2% nucleotide difference between the years. And for the first time globally, we reported 11040 sequencing type. And this is due to the selective pressure from the using antibiotic that I mentioned before and the environment. What about Salmonella enterica? The bacteria that's clustered phylogenetically together with similarity 99.96 nucleotide identity between the isolates of the same serotype. We reported 3 serotype of Salmonella, Munchen, Entertidis, Paratyphi. But was the first time why we reported Munchen as a dominant serotype of Salmonella enterica. And when we checked, we found carrying a plasmid called mobilized element, plasmid called PESI that make this bacteria to be upgrade, to be more virulent and more resistant genes, and make this bacteria to be the dominant serotype. This plasmid is self-mobilized and environmental tolerance. So that means can transfer horizontal transmission from bacteria to upgrade this bacteria and to make it more resistant. So that can transfer to E. coli or Klebsiella and to make it more resistant, carrying more resistant genes. The project that concluded that, here we see urban area, well-planned urban area, and advanced hospital, in addition to rural areas. The wastewater from all of this is that released to environment. And we see here the animal grazing on the wastewater. By horizontal transmission, similar what we saw in the plasmid PESI in Munchen bacteria, can transmit it to the bacteria to the sheep that grazing here, from the environment to sheep, and transfer to the microbiota of this sheep, and change this bacteria that's to be more resistant to carrying resistant genes. The product of this animal sell again to the people living in the urban area, maybe the hospital. And the bacteria still evolving in this system. and circulating in this system to evolve similar what we saw in Campylobacter, to be changed, to be more virulence. And I'm afraid to say that this is sentence. I expect if we continue with this situation, this advanced hospital will not be able to treat all the cases of antimicrobial resistance if we didn't break down the transmission pathway between the environment, animal, and the human. Based on the experience from the project, I can mention to the key challenges that conducted AMR integrated surveillance in conflict zone. First, logistical delay due to the war. Challenges securing sequencing services, financial and administrative issues, human resources and staffing challenges, restrictions on movement and for the surveillance system, shift in government priorities because we are living in emergency situation. Now, what we are doing currently, the ongoing project for antimicrobial resistance surveillance in the West Bank, integrated control and mechanism by targeting wastewater-based surveillance. The project, because we believe at the Institute of Community and Public Health and in One Health approach, we have to apply transdisciplinary approach by including all the partners, not only human medicine, but also the veterinary medicine. Environmental sector is very important, crucial, important. So we are using wastewater-based surveillance and conducting metagenomic analysis. And here the agreement that signed between the president of Birzeit University and Ministry of Health, in addition to Palestinian Water Authority. Here is my team in this project, that field team that conducting the research. I respect them a lot because they are working in this situation, under the war, under the conflicts, in this risky places. Sampling continue. We didn't stop, we continued. And now we have 6 tera of data results from the metagenomic analysis. We established this is Palestinian Water Authority conducting the sampling and mapping using GIS. Ministry of Health conducting diagnosis and helping in the sampling, the Environmental Health Department at the Ministry of Health. The analysis conducted at Institute of Community and Public Health. Together, we will take the decision by establishing the national committee that take the decision based on the evidence we have to build our strategy and to improve the national action plan that we have. This is my team from the field, from the lab. And at the end, my message for all of you that I want you to remember tomorrow morning that partnership strengthening our effort and increase our impact. Thank you.
Thank you very, very much, Dr. Said. Dr. Said said he wants you to remember tomorrow morning that partnership is very, very important. I really want you to remember it today and start acting on it today, that the issue of antimicrobial resistance is not an issue that that an individual can address in his silos. We all need to work together. Collaboration is very important. Cross-sectoral collaboration, cross-national collaboration, cross-institutional collaboration is very vital in order for us to win the fight against the scourge of antimicrobial resistance. Ladies and gentlemen, I want to thank Dr. Said for his excellent presentation so far. It's been very, very wonderful, and we have to transition swiftly to the question and answer session. So Kekeshan, please, if you can bring all of the speakers on the screen, and let's get busy with question. Audience, you are free to use the Q&A box. Please just type in your question, and then we'll take the question and serve the speakers accordingly. Dr. Mohammed is here, Dr. Said is here, Dr. Heba and Dr. Kuya as well. They are speakers too, and we really want to get busy with the conversation. So, Dr. Mohammed, the first question that we have for you is, with genomic surveillance expanding rapidly across the MENA region, we are wondering what practical steps can countries with limited lab capacity take today to begin integrating, of course, integrating genomics into their AMR response without waiting for major infrastructure investment. If you didn't get me clearly, I would like to take it again. With genomic surveillance expanding rapidly across the MENA region, what practical steps can countries with limited lab capacity take today to begin integrating genomics into their AMR response without waiting for major infrastructure investments? Dr. Mohammed, that's for you.
Okay, thanks for this question. So, as you know, there are many capacity building initiatives like the Bill and Melinda Gates and Fleming funding, etc. These are capacity building initiatives not from Africa, but from the high income countries towards Africa. I personally believe that they are nice initiatives like this, but it won't gonna work. So the best initiative that we are planning to do is to have a regional hubs for like sequencing, and like that provides not only sequencing services but but also like a one consortium of scientists that actually implements the sequencing. So if most of these countries, as Dr. Saeed was mentioning, like the sequencing capabilities in Palestine or any part of the world, we can host maybe in Egypt or wherever some of these hubs that can provide not only capacity building for sequencing, but also training and knowledge transfer in this area. So it's an open access resource for most of the people in this area. So I believe this is one of the initiatives that I dream of doing to help the low and medium income countries implement genomic surveillance and all microbial genomic studies in the region.
Thank you very much. That was apt. Dr. Said, a quick question. Someone is asking, how are antimicrobial resistance containment plans, such as national action plans and other strategies, financed in Palestine? And if funding is a challenge, why make it so challenging to attract financing for AMR containment plans? I don't know if you get the question clearly, sir.
We are talking about the financial or the fund, of course. Palestine, similar of all countries that impacted from the CDC clause or USAID. All of this is organizations that support the low and middle income countries. All of supports that supports from WHO supporting the government sector. Regarding further research, we receive supports from fundraising for organization worldwide, Horizon EU, for instance, EU countries. So it's depend on individual and institutional efforts more than of systematic we have it. The idea is that in Palestine, we depend on financial support more on the NGOs. Even the government also receives support from the World Bank, all of this organization. By the way, we have now a pandemic fund project that from the World Bank, that's for pandemic preparedness, AMR part of this fund.
Thank you. Thank you so much. Dr. Heber, you are the second speaker on antimicrobial resistance from the One Health lens, and this question is specifically for you. And the person is asking, in applying the One Health lens to antimicrobial resistance, what is one intervention you believe is currently undervalued, yet could create the biggest ripple effect across human, animal, and environmental health if scaled across the MENA region? Dr. Heber, that's for you. And if anyone on the call want to contribute, please, you are welcome to do that as well. Okay, let me push that to Shafi. Shafi, do you mind lending your voice on that? I can't hear from Dr. Heber at the moment.
Yeah, can you please just repeat it for?
Yes. The question is, in applying a One Health lens to antimicrobial resistance, what is one intervention you believe is currently undervalued, yet could create the biggest ripple effect across human, animal, and environmental health if scaled across the MENA region?
Thank you so much. So that's a very, very important question. And of course, there is always a concern how to achieve this. Of course, when we say about the antibiotic use or antimicrobial use across different sectors, one of the key stakeholder that is often quite undervalued is the end users, the farmers, the agriculturists, people who are using those antimicrobials at the end. Of course, we reach to the middle stakeholders, but ultimately reaching to the ground level of getting them aware of why we are talking about these things, and also finding alternatives. At some point of time, maybe like several decades ago, we had several other natural methods of controlling infections. And if you see the trend in the Europe over the last several, I would say, couple of decades, there has been a substantial investment in reducing the use of antimicrobials in non-human health sector, which actually has shown effect by reversing the effect of these use of antimicrobials in human health resistance. So that is something which is really achievable. The thing is, we need to find out and invest in solutions which are more eco-friendly and which do not need antimicrobial medicines to reduce infections and protect the crop. No, we cannot say, no, you don't use antimicrobials anymore. We want to protect, we want to reduce antimicrobial resistance in human beings. That's not simply going to happen, because we have to consider it, and we have to be very concerned about food security, which requires a lot of control of infections. So I think we need to bring the ultimate stakeholders into the discussions. Second thing, we need to really invest and learn from other countries to reduce the use of these medicines and come up with other alternative solutions.
Right. Dr. Mohammed Al-Kadi, is there a comment you'd like to lend to this? Because the question is a very concerning one. One Health is an issue that we really want to intervene, that we really want to implement. But are there some interventions you believe that are currently undervalued, and that if these interventions are scaled across the MENA region, it could actually help in curbing the rise and spread of drug-resistant bacterial infections in different settings?
Yeah, I think my colleagues have beautifully covered the topic in the context of the MENA region. But what I want to say, last message, that we have 4 pillars that we need to make sure that already practiced, decided, endorsed, and implemented. The first pillar is policy harmonization, alignment, nationally, locally, nationally, and regionally. And the second is really a huge investment in public health surveillance systems to be integrated at the country level. And also it's kind of building an idea of having kind of regional public health surveillance interconnected with every context in the region. And we need to unify the research efforts in order to generate more knowledge and evidence on. It is still limited, the knowledge and evidence on AMR in our region, especially in low middle income countries. So we have diverse contexts in the region. So we need to increase the knowledge and evidence on it to be used in the implementation and the practices. And the last point, really we have to think about collectively, to think about sustainable funding mechanism from all funding sectors, whether private, government, philanthropic. So we need to work on this very strongly in order to have maybe a regional fund for financing One Health implementation programs and the project. So this is, I think, my colleagues have covered this technically, scientifically, and practically. And I think to move forward, we need to collaborate together to continue this journey in alignment with other efforts that is happening in the region. And yeah, this is my last message, emphasizing on these 4 key pillars. Over to you. Thanks.
Thank you very much. Dr. Say, a question for you is, Given the unique challenges of fragile health system in Palestine, for instance, are there some innovative or community-driven strategies, that have proven surprisingly effective in supporting antimicrobial resistance control despite limited stability and resources that you would love the world, to leverage on? Because unrest is not peculiar to any region. It can happen anywhere at any time, and we can learn from party A and see how we can leverage that also in party B to mitigate the scourge of AMR.
Yes, many thanks for this excellent question, because if you live in this area, it's always this, I face this issue to illustrate what our situation we have. It's not easy to reflect or to send your message smoothly for the people living in suitable places or stability places. So for instance, for us, area A, the Ministry of Health control everything. Area B, just only Ministry of Health have access for some clinics. Area C, under the clinics for not always under control of Ministry of Health. In addition, we have the refugees camp under UNRWA. This is completely out of the Ministry of Health responsibility. This is why we are talking about a fragile health system. So if you have a policy, you want to apply it in different places, you will face obstacles. You will face a lot of issue in your applying your policy. What we are doing now in the using wastewater-based surveillance, we are applying the wastewater-based surveillance because we don't have access to some areas for an area C. So we're using the wastewater, antimicrobial resistant genes burdens or abundance to see reflect what is happening in the community, to determine what we have and to predict in the future. Maybe some of Dr. Muhammad know very well, we have silent genes. So not all the susceptibility tests reflect the silent genes. So we are now doing the metagenomic analysis with D breeds, 198 million D breeds on each samples. This is why we have 6 tera of the data in the first phase of the metagenomic analysis, to see what is happening in some areas we can't reach. And then we establish the committee to take the results for the some of NGOs working in this area to establish decentralized system for the treatment or to reduce the abundance of antimicrobial resistant genes. Because we can't go for a centralized wastewater treatment plant because we are fragmented. And here, why we need the evidence to build a policy to establish the sustainability.
Nice. Thank you very much, Dr. Said. I think this is really, really impactful. So a question that is for all of you on the panel, Dr. Said, Dr. Shafi, Dr. Mohammed, and Dr. Mohammed El Hadidi. This is a very nice one, and we really will appreciate your collective responses on this, and you can give this as your closing remark as well. Now, as an expert in the field of antimicrobial resistance, a few of you are professors in AMR, epidemiology, genomic surveillance, and some are the focal person for AMR, IPC, and all of that. If you were given the power to implement just one cross-sector, one health action across the entire MENA region, starting today, what bold move of you choose? And why will you choose this particular move? Dr. Shafi, I would like to start with you.
Thank you. So I think, we need data for action. So if there is one thing to choose, I will go for an improved surveillance system with built-in capacity in the country levels to really do One Health surveillance.
Awesome. Dr. Mohammed El Hadidi.
I was going to say the same about surveillance. We all know that as academicians and as policy makers, that knowledge is power. So surveillance is really crucial, and most of the funders, unfortunately, doesn't value this because they say that's basic science research. But if I will vote for one more, it's cross-border collaboration. Like One Health is actually not implement like the intersectorial between disciplines, but also the collaboration between different countries. So let's say that like we act local, but we actually implement this in a global way.
Thank you. Dr. Mohammed Al-Khadi.
Yeah, in short, we can actually think about, regional hub or advisory board to focus on three things: policy harmonization and alignment, and then building data to envision the way and to practice or to act. This is actually a simple statement that can be.
Excellent, excellent. Dr. Say, what's your take on this?
Yeah, actually, I have many of things to apply it based on my experience. So
Yes.
one sentence that I mentioned, partnership. Of course, I would like to go, if I am going to National Action Plan, the fifth, I will choose to be precise, integrated surveillance system. Not only surveillance, because we have medical surveillance, we have veterinary surveillance, we have environmental. We need integrated surveillance system and data sharing between all the sectors, and to be practical, not only words on the paper. Just only we need the decision makers hear us and working together to apply real integrated surveillance system.
Thank you very much, everyone. That was very, very straight to the point. Integrated surveillance system. And, all of our action plans should not just be action plans on paper. All of these action plans should be backed up with action. Financing is necessary. A policy implementation is necessary, and we must work together as a team in order for us to win the fight against this scourge of antimicrobial resistance. Dr. Heber, you're back. Your hand is up. Please share your thoughts on this. I really want to hear from you.
Yeah, sorry for the connection. So building bridges of trust between the partners, stakeholders, I guess this is the key around sharing responsibilities as well as sharing the credit as well is a key for any collaboration and coordination and to tackle any health threats in the human-animal environment interface, including AMR for sure. Thank you.
Awesome, awesome, awesome. Thank you. Thank you so much. That was straight to the point. Ladies and gentlemen, we are gradually coming to the end of our webinar. I would like to bring to the fore my colleague, Miriam, for her to make her presentation. Miriam, if you're ready, we are ready. We'd love to hear from you. Over to you now.
Hello. Thank you very much, Hamyu. My name is Miriam Waqaf, and I'm a technical working group member with the Global Health Network, MENA. I'm sorry, I'm unable to open the video, so feel free to open it if you can, or start my video. Okay, all good. To begin, I would like to extend our sincere gratitude to our distinguished speakers, Dr. Muhammad, Dr. Hiba, Dr. Shafi, and Dr. Saeed. Thank you for the time, the depth, and clarity you brought to this important discussion. I can say personally that I have learned so much from you today. As we have seen throughout the session, antimicrobial resistance remains one of the most pressing public health threats for our time, and even more so for the MENA region. The insights shared today highlight not only the complexity of this challenge, but also the tremendous innovation and commitment demonstrated across the region and within diverse contexts. We heard about the adoption of One Health approaches, bringing together multiple sectors and actors to tackle AMR collaboratively. We explored the needs and advancements in integrated and genomic surveillance, as it has been reiterated, health research, the lack of sufficient data and data sharing, early warning system, and the development of alternative approaches and measures, as well as ongoing efforts to promote preventative measures and reduce overuse. Our speakers also presented valuable tools and frameworks that can support countries in strengthening their response and driving progress forward. A key message that resonated with me in this session was the importance of engaging more stakeholders and expanding multi-sectoral collaboration. This discussion today underscored the region's growing holistic, coordinated and strategic response, one that acknowledges the scale of the challenge while also demonstrating clear pathways for collective action through plans and through the One Health approach. I would also like to take a moment to thank the incredible teams behind this event. Thank you to WHO EMRO, thank you to the Global Health Network, with special thanks to the UK, Africa, and MENA teams. Many thanks as well to Dr. Khaldi, Dr. Marina, who, although unable to join today, has supported immensely in organizing of today's event. And a huge thank you to Dr. Ohamiu, who is not only a colleague, but also a peer, and whose passion for AMR has inspired many of us. On behalf of our cohort, I would like to say thank you, and that we are very proud to see the way he continues to raise awareness and advocate for action on this specific issue across Africa, the States, and on a global level. And of course, my heartfelt thanks to Dr. Trudy, who brought all of us together by establishing this powerful network and fostering the collaborative spirit that defines our work. And last but definitely not least, thank you to all the participants who joined today. I'd also like to close by inviting you to join the network, where we can tackle this issue as well as many other issues, pressing issues in the health systems and in the healthcare, the global healthcare landscape, working across the globe while recognizing simultaneously the different issues faced by respective regions. Thank you all so much.
Thank you, Miriam. That was wonderful. Thank you, colleagues. Thank you, speakers. We had a very nice session, and I'm very happy. I feel super duper excited that we are bringing to an end officially the AMR Awareness Week webinar series of the Global Health Network. On Tuesday, we were in Africa. On Wednesday, we were in Asia. On Thursday, we were in Nigeria, and today we are in MENA region, and it's been very wonderful. We really appreciate all of our resource persons and all those who attended and those who registered. We are very grateful. The content of this recording will be made available on the Global Health Network and also on the AMR Knowledge Hub as well. You can reach out to us, for the material. You can visit the hub and download as many resources that will help you in your research. So from every one of us here at the Global Health Network, all of my team, Kekeshen, Lily, Nana, Chinemye, and all the resource persons, Adam and the rest, we are very grateful for all of your support and for your presence. Thank you so very much for availing yourself to serve in the capacity assigned to you. And as we close, please, we are not closing AMR initiative. Let us go out and act and collaborate and synergize together and integrate together. This is the only way. It is through One Health approach that we will be able to win the fight against the scourge of antimicrobial resistance. Until I come your way again, I remain your friend and your colleague, Ohemu Godwin Pius. Thank you so very much for joining us, and do have a wonderful weekend. Bye for now from all of us at the Global Health Network.